Welcome to our lecture on mental disorders. In this lecture, we're going to define mental disorders, talk about how they manifest or develop, uh, talk about the most common psychological disorders, so we can differentiate between those psychological disorders. And then lastly, we'll talk about prejudice, stereotype, and discrimination, and how we can reduce stigma associated with mental disorders. So first, how would you define a mental disorder or a psychological disorder? So the APA, the American Psychological Association, defines psychological disorder as a clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and that is associated with present distress or disability or with significantly increased death, pain, disability, or an important loss of freedom. And so what we see in mental or psychological disorders is really a failure to adapt to the environment, failure to be able to function in daily life, and some type of disruption in thoughts, moods, or behaviors. And so the textbook definition is pretty spot on with that, in that it defines mental disorders as disorders that disrupt thinking, feelings, moods, and behaviors and cause some degree of impaired functioning in daily life. And you really need both of those aspects, which we'll see when we talk about categorizing mental disorders. So just a historical perspective, throughout history, people have recognized that certain behaviors are abnormal, yet their explanations for why these behaviors happen have changed over time. So during the Middle Ages, people believed behaviors associated with mental illnesses were due to evil spirits infesting the body, and treatments were to perform exorcisms and to release those spirits from the body. And we still see that in some cultures today. During the Renaissance, people began to view mental illnesses as a physical disorder requiring treatment, and this view was called the medical model. However, sometimes the treatment for these mental disorders were pretty barbaric. So bloodletting was very popular. They'd also push people into snake pits, thinking that they could frighten people out of their diseases. In the 1800s, reform came and advocated for more moral treatments, insisting that those with mental illnesses be treated with dignity, kindness, and respect. So one thing I just want you to remember that what is abnormal is shaped not only by history, but by culture as well. To facilitate diagnosis, psychologists have adopted a way to classify mental disorders. In 1952, the first version of the Diagnostic and Statistical Manual of Mental Disorders, usually abbreviated DSM, was published. These early versions provided a common language for talking about disorders, but the diagnostic criteria was still pretty vague. The most current version of the DSM is the DSM-5. Each disorder is named and classified and thought of as a distinct illness, and a lot of it is evidence-based through research of studying people with mental disorders. There are three key elements that must be present to qualify for a potential mental disorder. One, a disorder is manifested in symptoms that involve disturbances in behavior, thoughts, or emotions. Two, the symptoms are associated with significant personal distress or impairment. So significant personal distress or impairment. And three, the symptoms stem from internal dysfunction. And this just means that it can't be brought from like a drug. So if you take LSD, have a trip, have hallucinations, that's not a disorder. Psychological disorders exist on a continuum from normal to abnormal. And so the DSM-5 has a global assessment of functioning from 0 to 100 that rates each person, and more severe behaviors are indicated by lower numbers. So why do we classify individuals? So psychiatric diagnoses serve at least two crucial functions. One is they help us pinpoint the psychological problem a person is experiencing, and two, it gives us a common language to communicate with each other. When one psychologist or psychiatrist diagnoses a patient with schizophrenia, another doctor or psychologist can know what that means. So it's a shorthand in some way. Some people have pushed back about this idea that classifying or labeling people are with mental disorders as helpful. So Thomas Shazaz believed that mental illness is just a myth based on labeling people instead of labeling behavior. So the diagnosis of something leads us to treat that person differently, perhaps leading us to turn to that person to behave in pathological ways. So they're self-fulfilling prophecies. Basically, you slap a label of depression on someone, we start treating them differently because they have the label of depression, and then they start believing they are different because of how we're treating them. A really famous study was Rosen and his grad student. So Rosen was a psychiatrist, and he sent his grad students to different mental hospitals and had them claim that they were hearing voices. Each grad student was admitted to their mental hospital that they went to, and once admitted, they said they were no longer hearing voices. So they'd go up and say, I'm hearing voices. And so they'd get admitted. And once they were admitted in their first session, they're like, I don't know, nothing's wrong with me. Even so, hospital staff was reluctant to identify these patients as normal, and it took an average of 3 weeks for these grad students to get released. And often they were released with a diagnosis of schizophrenia in remission. So this study is really controversial. Obviously, ethical implications of sending your students to mental hospitals and having them be there for 3 weeks is unethical. And I think it'd be interesting. We'll hear about schizophrenia in a second, and I think schizophrenia would be one of the harder ones to um, be unlabeled from once you get labeled, and we'll see about that in a second here. But so what is the effect of labeling someone? Psychiatric labels can have negative consequences since many of these labels carry the baggage of negative stereotypes and stigma. And this may explain why 70% of people with mental illness do not seek any type of treatment. However, there is not evidence that the diagnoses themselves generate long-term negative effects above and beyond the effects of the disordered behaviors themselves. So what we're going to do today is go over basically the most commonly diagnosed disorders and some of the ones that are more well-known or kind of popular in media, just so that you have an understanding of what those are. So we're going to start with schizophrenia. This is the probably most severe of all mental illnesses. It's a devastating disorder of thought, emotions, and you basically lose contact with what is real. You can't differentiate between what is real and what is not. And for you, with schizophrenia, everything, your hallucinations, your delusions are 100% real for you. Some people have called it the cancer of all mental illnesses because it is so severe and debilitating for people who have it. It is characterized by profound disruption of basic psychological principles, um, a distorted perception of reality, blunted emotions. We call this a flat affect. So not showing emotions in your voice, and disturbances in thought, motivation, and behavior. Schizophrenia is diagnosed when you have two or more of the following symptoms in a 1 month period for at least 6 months. So you can have like it for 1 month and then not have disturbances and then kind of have disturbances again. So some of the characteristics or symptoms that we would see in patients with schizophrenia are delusions. So this is just false beliefs, often really bizarre or over the top to us, but they are really, the people with schizophrenia cannot understand that these are false, that these are not true. So many people believe they're Jesus Christ or some famous person. Delusions of being persecuted are also very common. And again, there's no way to reason someone and say you're not Jesus Christ because they 100% believe they're Jesus Christ. Hallucinations are a false perceptual experience that has a compelling sense of being real despite the absence of external stimulation. So this could include hearing, seeing, or smelling things that are not there. 65% of patients report hearing voices. And in one brain scan imaging study, when people were experiencing auditory hallucinations, we saw an activation in Broca's area, the part of the brain associated with production of language. And so there are you know, real things are going on in the brain to manifest these symptoms. We also may see grossly disorganized behavior. So this is behavior that is inappropriate for the situation or ineffective for the situation. So childlike silliness, disheveled experiences or disheveled appearances. So just kind of not being able to keep up with how you, uh, the normal kind of look of society, loud shouting, strange movements, odd mannerisms, catatonic behavior, which is kind of a decrease in all movement. We see negative symptoms, and negative means absence. So again, that kind of flat affect, the absence of emotions. They may socially withdraw. This occurs in only 1% of the population and typically occurs first in early adulthood. We don't see the first signs of schizophrenia until early 20s most of the time. Sometimes schizophrenia is called or split mind, but it's not split personality or multiple personality disorder. This is like a huge misunderstanding. But schizophrenia, the meaning of schizophrenia, if you break it down into word parts, means split mind, not split personality. So split mind refers to the fragments of thought, processes, and emotions, not the personality. So it's that the mind gets the thoughts in the mind get all kind of scattered and split up and they don't make sense. And it's not about having multiple personalities. That's not what schizophrenia is at all. And we have a pretty good example of schizophrenia from Dr. Sachs here, who is a schizophrenic and also a professor. And she talks about her experiences. And one thing that I think you can really notice in this video is her flat affect. She has a really just monotone voice and doesn't, so her retelling sometimes is difficult to understand where her sentences stop and start. And it's all just kind of one monotone voice because there's that lack of emotion or flat affect in her voice. So who gets schizophrenia? I think with all of these diseases, we're not like 100% sure, and not one thing probably causes, not one aspect or one cause causes all of these disorders. And so genetics may definitely play a role in all of these disorders. People with a family member with schizophrenia are more likely to develop this disorder, but we also think prenatal environment may play a role. So when one twin is diagnosed and the other twin is not, the diagnosed twin has a lower birth weight and was born second. In addition, this is like really random, I think, but people born in late winter and early spring have about 20% greater risk of schizophrenia. And this may be that they were exposed to some kind of virus during the critical period of their brain development. Dopamine is also likely to play some role. Reducing the amount of dopamine activity in the brain by drugs can help reduce or eliminate some symptoms of schizophrenia, but it doesn't help with all of the symptoms of schizophrenia. And so sometimes it also makes symptoms worse. So and another more psychological explanation is the Diathys stress model. So this is really a common kind of hypothesis for a lot of different disorders. And this suggests that stress plays a role in triggering schizophrenia in people who already have an inherited predisposition toward the disease. So basically, you already have increased likelihood of getting schizophrenia, maybe genetics or something in your environment early on. And it isn't until later in life, your early adulthood 20s, that you have a stressful event or a series of stressful events, and that kind of kicks off the manifestation of symptoms of the disease. And that this Diathys stress model is a pretty common explanation given for our diseases, our disorders that happen to start later in life, like schizophrenia. Okay, so moving on to dissociative disorders. So most of us think about ourselves as one identity, like you are one whole person. People with dissociative disorders experience a serious disruption of their thoughts or behaviors that prevent them from experiencing a healthy, consistent identity. So dissociative disorders are conditions in which normal cognitive processes are severely disjointed and fragmented, creating serious disruptions in memory, awareness, or personality that can vary in length from a matter of minutes to many years. So dissociative disorders are called so because it involves a splitting apart or disassociating those significant aspects of experience from memory of consciousness. So basically, you experience something and it is so traumatic to you and your identity that you need to basically form another identity or forget your first identity to be able to cope with it. That's really kind of the easy way to think about it. Dissociative identity disorder is the presence within an individual of two or more distinct identities that at different times take control of the individual's behavior. This was once called multiple personality disorder. The number of distinct personalities that a person can have can range. It can be up to 1,000. Some personalities are similar, some are dissimilar. They may have different vocal patterns, dialects, ages, and even gender. About 1% of the population has this disease. It's more common in females than males. And again, it's diagnosed usually in the early 20s, but stems from childhood trauma most of the time. So we just talked about dissociative identity disorder, which is this bottom one. So more two or more distinct personality traits. There's also dissociative amnesia, which is the sudden loss of memory for significant personal information. So these patients are retaining their identity, but lose memories of events for a period of time. And then dissociative fugue is the sudden loss of memory for one's personal history. So they basically lose their identity. Often these people kind of just leave their home because they don't recognize that this is where they're supposed to be or where they live. And they assume a new identity and just kind of go and live a new life someplace. There are two main explanations for dissociative disorders. One is the post-trauma explanation. This is that kind of like how I explained it before, that dissociative identity disorders arise from a history of severe abuse, physical, sexual, or both during childhood, and abuse leads individuals to compartmentalize their identity into alters as a means of coping with intense emotional pain. About 90% of all of those people with dissociative identity disorders have a history of childhood abuse. So that's one reason. The other reason is a more kind of sociocognitive model explanation, is just that therapists, along with the media, are creating these alternate personalities, instead of discovering them. So the evidence for this is that in 1970, there were 70 documented cases of dissociative identity disorder in the world. By 1986, there were 6,000 cases. What happened in that time period? A pretty famous book came out about someone with multiple personalities, got a lot of media attention, more and more people were diagnosed. This was also, like, if you're into serial killers, this is also the time when there were some serial killers that claim that they have dissociative identity disorder too, or multiple personalities. Okay, so those were the kind of rare, more or less common disorders but those two I feel like you hear a lot about in the media, and they often get confused. So that's why I wanted to start with them. Now we're going to switch to disorders that are much more common. Okay, so mood disorders are mental disorders that have mood disturbances as their predominant feature. So they can take two main forms: depressive disorders and bipolar disorders. So we'll talk about depressive disorders first. And these are some quotes from Winston Churchill. He wrote a lot about his mental thoughts. And so everything that was once new, or everything that once was sparkling now was flat. I doubted completely my ability to do anything well. From the time I woke up in the morning until the time I went to bed at night, I was unbearably miserable and seemingly incapable of any joy or enthusiasm. Everything, every thought, word, movement was an effort. And I like using some of these quotes because I think they really resonate with how depression can feel. And the reason there's a black dog in the picture here is that he often wrote about his black dog, which was a metaphor for his depression. So when his black dog is there, everything seems dark, everything seems gray. When he's away, all the colors come back into the picture. So this is a pretty common metaphor to describe depression. And of course, as an animal lover, I don't like this metaphor, but I think it is helpful in kind of understanding what depression can feel like. So most people do feel occasionally depressed, pessimistic, unmotivated, but these periods are relatively short-lived and mild. Depression is much more than such sadness. Some symptoms of depression are losing interest in socializing, gaining weight, having trouble engaging in activities that you normally enjoy, having trouble concentrating, being forgetful, having a sense of hopelessness or weariness. Depressive moods are dysfunctional, chronic, and fall outside of the range of socially or culturally expected responses. So major depressive disorder, sometimes referred to as unipolar depression as opposed to bipolar depression, is a severely depressed mood that lasts 2 or more weeks and with feelings of worthlessness and lack of pleasure, sleep and appetite disturbances. So sometimes it may be sleeping too much or sleeping too little, eating too much or eating too little. Other types of depression disorders are dysthymia, which is depression that lasts 2 years. So the same as major depression, just longer. Seasonal affective disorders, which you may have heard of, are recurrent depressive episodes in a seasonal pattern. So most of the time getting depressed in the wintertime when it's dark more. On average, an episode of major depression lasts about 6 months, and without treatment, 80% will experience recurrence. The general population is diagnosed at a rate of 16%, so just 16% of the general population has depression. Women are diagnosed twice as much as men, which may be related to some kind of hormone estrogen thing. Other explanations for depression are, of course, genetics, biological factors. So we know that drugs that increase serotonin and norepinephrine can sometimes reduce depression, but antidepressants take at least 2 weeks to relieve depressive symptoms, but it takes less than 1 day for those medications to change neurochemical transmissions. So it's unlikely drugs are solely the reason for depression. Depression can be caused by negative beliefs and expectations. It's a negative view of oneself, one's experiences, and the future. And so it's really these cognitive distortions. And so just like schizophrenia in the way that your thinking is distorted, in depression, your thinking is distorted as well. Kind of the good aspect of depression is that you can figure out, you have enough awareness that with help, you can kind of rein in those cognitive distortions. Whereas in schizophrenia, there's no kind of reasoning through. In depression, we can use therapy to help you understand how these thought patterns are not realistic or not true to your actual life. So one other explanation of depression is learned helplessness. This is this slide. Learned helplessness is the tendency to feel helpless in the face of events we cannot control. And so I'm going to go through an example here of taking a test. So when you take a test and you don't do well, you can have internal or external explanations for this event. So internal explanation would be, I'm stupid, I failed this test. An external explanation would be, the test was written too hard, that's why I failed the test. The professor didn't write the test well. So external to you, you're blaming something else, or internal explanation is that you're blaming yourself. Global or specific. So again, with the same example of test taking, failing a test, global would be, I fail all tests. Specific would be like, this isn't my area. I just failed this test, or just this one test. I'll get it next time. Stable or unstable is I fail all tests all the time. And unstable would be, again, just this one test, this one time. It's hard for me. I always think of global and stable and specific and unstable to go together, but you can see there that when you have an internal, global, and stable explanation for events, it's all on you. It's all internal. And that usually is how people with depression think. So I'm the cause of all bad things. I'm always the cause of bad things, of all things. So I'm the cause, all things, always. And that can be, really hard to handle as a way of thinking about events in your life. And that's not usually true. And so we'll talk in a bit about how we can kind of rearrange that thinking to make it healthier. Okay. So along with depression, along with mood disorders, we have bipolar disorder. So bipolar disorder is abnormally high moods, referred to as mania, alternating with periods of crushing depression. So bipolar is that you have both the high end, the mania, which is feeling really good, feeling happy, feeling like nothing can slow you down. And then the other end is depression. So feeling hopeless, that everything's your fault. So these are it's an unstable emotional condition characterized by cycles of abnormal, persistent high mood, mania, and low mood depression. And about 2/3 of patients with bipolar disorder, manic episodes immediately precede or immediately follow depressive disorder. And a lot of times this is misdiagnosed as depression at first because the depression that you experience with bipolar is the same that you would experience from major depression. And people often seek help when they are just in their depressive episode. In the manic phase, to meet criteria, mood must last a week and be elevated. Symptoms include decreased need for sleep, talkativeness, spending sprees. They may also include hallucinations or delusions. This occurs in about 1.3 of the population, more common in women than men. It's a little bit hard to treat. So 77% of people will relapse in 4 years, mainly because some of the medicines used to treat it, people generally like the manic phase of it in a way because they can be really productive, they can get things done. And so a lot of times people don't want to take their medicine because the manic phase feels good in a way. And so they don't want to get rid of that. So the reasons, the causes, again, a pretty high genetic component to this, that, if someone in your family has it, you're at an increased likelihood to have it. Biochemical imbalances, just like we talked about with depression, again, somehow related to neurotransmitters. And the diathys stress model, again, stressful life experiences often precede manic and depressive episodes. So again, just something that like stress kind of sets off these episodes with people with a pre-existing vulnerability. The treatment is lithium. Lithium is like a drug, and again, like I said, it balances you out, but people often don't like to not feel the highs. And that can be, and there's other side effects too that make the medicine not very pleasant. So overall, biological factors do play a role in mood disorders. You know, certain neurotransmitters like serotonin, dopamine also seem to play a role. Um, Again, genetic factors, mood disorders are inherited for the most part. 50% chance that twins have the disease or have a disease. And then our psychosocial explanations are the environmental stressors and disturbances in a person's relationships, thought processes, self-concepts, and history of learned behaviors. So just like how we explain what happens to us matters, and that can be a pattern of thinking. So depression occurs when people become resigned to the idea that they're helpless to escape something that is not good, that is painful maybe, or just not healthy for them. Okay, moving on to anxiety disorders. For most, everyday anxieties generally don't last long or feel especially uncommon. And anxiety in small doses can be adaptive. So when we feel anxious about something, it may steer us away from engaging in harmful behaviors, or it may give us that little boost of nerves to solve things that are kind of festering. Yet sometimes our anxiety spirals out of control and it can become excessive and inappropriate. And when anxiety arises that is out of proportion to the real threats we're experiencing, it is maladaptive. So anxiety disorder, people often experience more than one type of anxiety disorder at a given time. And there is significant comorbidity, which just means there's significant, people get diagnosed with both anxiety and depression at the same time. Anxiety disorders are phobic disorders, panic disorders, generalized anxiety disorders, obsessive compulsive disorder, and post-traumatic stress disorder. And like I said, people often have more than one anxiety disorder. Anxiety disorders are among the most common of all mental disorders. About 29% of us will meet the criteria for one or more anxiety disorder in our lifetime. And we tend to develop anxiety disorders early in development. So the average age is actually 11 years old, which I just find unbelievable. Okay, so going through some of these anxiety disorders, the first one, panic attacks. This occurs when nervous feelings gather momentum and escalate into intense bouts of fear. It can be characterized by sweating, dizziness, lightheadedness, racing heartbeat, feelings of impending death or going crazy. About 20 to 25% of college students report one panic attack a year. And panic attacks can happen in less than 10 minutes. Some people may initially think it's a heart attack. They may be associated with specific situations like public speaking or something like that. People suffer from panic disorder when they experience panic attacks that are repeated and unexpected, and when they either experience persistent concerns about panicking or changing their behaviors as a result of the attack. So what we see here is you have a panic attack when you have to, when you have to speak in class, and so you may start not signing up for classes where you have to speak, or missing days when you have to speak in class or something like that. And that's what becomes disordered because you're changing your behavior to avoid having these panic attacks. Another category under anxiety disorders are phobias. So phobic disorders are marked, persistent, and excessive fear and avoidance of specific objects, activities, and situations. The fear is irrational. So the person, again, kind of in differentiation from schizophrenia, people with anxiety disorders recognize their fear is irrational. So they understand that this fear is overblown, but they can't seem to prevent it from interfering with their everyday functioning of life. There are specific phobias. So fear of objects or situations, so animals, certain natural environments like heights, situations like bridges, blood, injuries. So 11% of people in the United States have a specific phobia during their life, and it is much more common among women than men. There's also social phobia, which is the irrational fear of being publicly humiliated or embarrassed. This typically emerges between early adolescence, so 13 or so, and age 25. And this occurs in about 11 to 15% of the population. Agoraphobia, this name of a social phobia comes from the ancient Greek when certain fearful citizens couldn't pass through the open air markets called agorias. So really it translates into fear of open spaces, which were angorias in ancient Greek. So it's not the fear of crowds or public places, but it refers to a fear of being in a place or a situation in which escape is difficult or embarrassing, or which help is unavailable. We do have some theories here. One is that as humans, we have just a predisposition towards certain fears, which is a survival thing. So we can be quickly conditioned to have a fear of snakes and spiders, but not as quickly conditioned to have a fear of like toy rabbits or flowers. So it's much more easier for us to be scared of something that is threatening to our life than to something that isn't threatening. So this may just be kind of an not overblown in the sense that a person is making it up, but just like it manifests as something in your body happens where you become fearful of something that you believe that your body believes is threatening to your life. However, this like conditioning or learned associations does not offer a complete understanding of phobias. Not everyone that is like has a negative association with an animal or a place will develop a phobia of it. So you can get bitten by a dog and not develop a phobia of it. And then some people have a phobia of feared objects without ever having been around them, right? Like I've never been really close to sharks, but I, don't want to be in the water with one. And so it's kind of difficult because there's a lot of ways that we can think about how people develop phobias, and it doesn't seem to be one common way. So I have a YouTube video for y'all to watch. And then generalized anxiety disorder, it's called generalized because they are unrelated worries and are not focused on any particular threats, but they are, irrational. So you're just kind of worried about everything. And people suffering from general anxiety disorder, this excessive worry is usually alongside 3 or more of the following symptoms: restlessness, fatigue, concentration problems, irritability, muscle tension, and sleep disturbance. And again, this kind of worry can produce a sense of loss of control that can be really difficult to manage. So it seems that simple decisions can become just overwhelming, that they're going to have dire consequences, and that can really produce, extreme anxiety and an inability to function in everyday life. About 3 to 5% of North Americans suffer from generalized anxiety disorder at some point in their life. Again, probably a biological, genetic, psychological mix of things that are happening here to cause it. It does seem more common in people who live in cities, have low income, or where, there's kind of economic or political strife happening. And then OCD is obsessive compulsive disorder. This is persistent, unwanted, fearful thoughts and irresistible urges to perform an act or repeated rituals, which help relieve the anxiety created by the obsession. So you have obsessions, which are repeated, intrusive thoughts, and then these real behaviors that basically are designed to calm those thoughts down. So obsessions and compulsions, just like the name, are the 2 key markers of this disease. Anxiety plays a role in this disorder because obsessive thoughts typically produce anxiety, and then you have those compulsions that you try to do to reduce that anxiety. 2.5% of people will develop OCD in their lifetime. The most common obsessions are about contamination, about death, about diseases, about orderliness. So you're really obsessed with being clean, everything being in order, and not having things be clean or in order causes a lot of anxiety. And so you do compulsions to try to ease that anxiety, which is cleaning, checking, repeating, counting. A lot of times you see, kind of the popular ways that this is shown in the media is someone counting through something that they do, clicking the light on and off 7 times before they have to leave the house. That makes sure that they know that the light is off before they leave. So it's trying to reduce that anxiety associated there. So the causes, there is a genetic component to OCD. We also seen some brain differences between people with OCD and without OCD. Again, some neurotransmitter, some drugs can reduce the activity and relieve some of the symptoms. And therapy works pretty well with OCD, and we'll talk about therapy in a little bit. I believe this is our last category of anxiety disorders are post-traumatic stress disorders caused by some type of trauma, which leads to repeated flashbacks, dreams, numbing, and avoidance of stimuli. It affects overall about 3 to 4% of the population, but 31% of veterans and 10% of people after a large traumatic event. So like a bombing or something like that, you'll see obviously an increase of people. And children are more vulnerable than adults to developing PTSD. The causes, biological, again, we see some brain differences, but we're not quite sure about, if it's causing it or if we see those brain differences after. And then learning, it's, the kind of classical conditioning of associating stressful events or these traumatic events with your anxiety, and that association gets kind of broadened over time. And so, if you're in like a war situation and obviously, loud noises are, can lead to death in those situations, then you get out of that situation and your body has generalized those situations to everyday situations. And so that can be why it's really debilitating. So overall, causes of anxiety disorders, We have psychological reasons, which could be, like we talked about, some faulty cognitions. So these are habits of thinking that make people prone to fear. So people are constantly scanning their environments for signs of danger, trying to stay safe. People with anxiety tend to magnify ordinary threats and be hypersensitive to those around them. We also have maladaptive learning, so resulting from that social learning or classical conditioning. So a stimulus that is neutral, so say a spider, becomes paired with a frightening event, say panic attack, and so it becomes conditioned. So people then avoid spiders to try to reduce anxiety. We also have biological factors. So one is that evolutionary predisposition that we talked about, that fearing something was fearing something that could lead to our death was healthy for our ancestors. But now it seems that maybe some people are kind of genetically wired to overreact to these fears. And then sociocultural factors, there's a sharp rise in anxiety disorders in the past 50 years. One thought behind this is that today's threats may be less identifiable and immediate, which may lead some people to become kind of really just hyper aware. We also see that anxiety disorders dramatically differ in form from other cultures, from culture to culture. So a lot of our social phobia centers from fear of criticism. In Japanese, in Japan, there's a social phobia that involves kind of a dread of doing something to embarrass others. So, there are some of these cultural pressures that can lead to anxiety. So overall, 1 in 5 Americans experience mental illness in their lifetime. 1 in 25 will live with a serious mental illness, which are like schizophrenia. About 3/4 of chronic mental illnesses have begun by the age of 24, and depression is the leading cause of disability worldwide. We do see, however, that even though these disorders can or do, like in the definition of these disorders, is that it's a functioning of everyday life that cannot, that is abnormal. They cannot function in everyday life. We see that nearly 60% of adults don't receive mental health services, and nearly 50% of young adults, youth age 8 to 15, don't receive mental health services. And that's alarming, I think, especially for kids, because we see, again, like with anxiety, that it starts really early, 11 to 12 years old. And so we need to help those kids, when these symptoms start to appear. We also see some racial differences. White Americans are much more likely to seek out services than other race ethnicities. So there are kind of 3 main treatment options that I'm going to talk about. One, just again, this is kind of like what we see in popular media a lot, which is the psychodynamic psychotherapy. This is rooted in Freud's psychoanalytic theory of personality, which, again, if you've taken psychology, you probably have heard, there's a conflict between your id, ego, superego. And according to psychoanalysts, a lot of your trauma stems from childhood events. And the therapy is that going over childhood events, going over dreams, and trying to get at the root of these problems. Psychoanalysts focus a great deal on early childhood events because they believe that urges and conflicts were likely to be repressed during this time, and that they are kind of coming out now because of that. This is a long therapy, takes 3 to 6 years often, with 4 to 5 sessions each week. And this is your kind of classical, like what a lot of people think of when they think about therapy. You're reclining on a couch, you're talking to your therapist, you're expressing what thoughts and feelings come to mind. The goal in this therapy is for clients to better understand their unconscious, trying to gain insight into their unconscious. This this may work with people with less severe disorders that are aware of their thoughts and feelings. It obviously would not work with schizophrenia. There are people who still use psychodynamic theory as a therapy process, and most of the current psychodynamic approaches focus less on this unconscious and more on conscious processes. The kind of gold standard of therapy today is cognitive behavioral therapy. This addresses irrational beliefs and uses behavioral methods to initiate behavior change. Very widely used, a relatively brief therapy. It can be, and it seems that it lasts longer than medication. So people with obsessive compulsive disorder who had CBT therapy, cognitive behavioral therapy, had fewer symptoms a year and a half after treatment compared to those who took medicine and stopped. For people with depression, about 40% of people treated with CBT therapy experienced relief and were less susceptible to relapse compared to those just taking medicine. Okay, so we're going to do an example to kind of show you what CBT is. So for example, a depressed person may think, I can't face going into work today. I can't do it. Nothing will go right. I'll feel awful. As a result of having these thoughts and believing them, she might call in sick. And by behaving like this, she won't have a chance to find out that her prediction was wrong. She might have found some things she could do, or at least some things that were okay to do at work. But instead, she stays at home thinking about her failure to go and ends up thinking, I've let everyone down. They will be angry with me. Why can't I do what everyone else does? I'm so weak and useless. And this probably ends up making this person feel worse, might even have more difficulty going to the work the next day. And this could become a downward spiral. So you can kind of see how, again, it becomes this self-fulfilling prophecy of, I can't do something, I'm never going to be able to do something. And at the beginning of CBT therapy, what happens is the client meets the therapist and describes the specific problems and set goals they want to work towards. So problems could be sleeping badly, not being able to socialize with friends, difficulty concentrating on work, being unhappy at work, being unhappy in marriage. So those problems and goals become the basis of planning the content of sessions and discussing how to deal with them. There usually is homework that the client has to do. And so the client or the homework is usually kind of keeping track of thoughts and behaviors around those thoughts. I think so. CBT, what happens is you want to try to deal with these negative thoughts. And so the first step is recognizing the negative thoughts. And so with homework, you may, okay, I feel bad about going to work. I think everyone's going to be mad that I didn't show up. And then you identify what triggered this emotion. What are you ignoring, minimizing, or exaggerating? Like, do you actually know the thoughts of other people? Has this happened before to you? And then the challenge too, where's the proof? Are my thoughts definitively or definitely accurate? Are there other explanations? And then reframing, so your thoughts are no longer negative, personal, permanent, and pervasive. And that's what we talked about before, that internal, stable, and global, right? We're trying to reframe that and not think in that way so that we are not being negative, we are not being internal, we're not being global, we're not being stable with these negative thoughts. And so by reframing our thinking from negative thinking, we can think about it in, not so, much blaming ourselves, but think about the more realistic way, what is actually happening. And then you may see positive outcomes occur. And so I'll try to find a video about this because I think CBT is an extremely helpful therapy. Again, it's one of the most widely used therapies for a lot of different diseases. Eating disorders have a good rate of success with CBT because at the heart of eating disorders are cognitive distortions. And so, what are my cognitive thoughts that are not true, and challenging those and then trying to reframe them. So a lot of the homework of CBT is during your week, between your therapy sessions, doing worksheets that really help you break down this thought pattern and try to change it. So lastly, our biological or pharmacological treatments. So biomedical therapy using drugs, electroconvulsive therapy, or psychosurgery to reduce or alleviate symptoms. So the premise of this is that these behaviors are caused, at least in part, by chemical imbalances or some kind of disturbed nervous system functioning or some kind of differences in the brain. So drugs are psychological drugs that act primarily on the brain. They act a lot on these different neurotransmitters, like I talked about before. We have antipsychotics, drugs, we have mood stabilizers, we have antidepressants, we have anti-anxieties. And so a lot of times we don't know how these drugs work, and they probably work on multiple neurotransmitter systems. About 10% of adult women and 5% of adult men are taking antidepressants. The thing with antidepressants are they definitely relieve symptoms, but they aren't curing the issue at hand, because a lot of times if you go off those medicines, your anxiety or depression returns. And there are side effects of a lot of those drugs. They may be overused. About 50% of the time a patient walks into a doctor's office, they are prescribed drugs for if they are saying that they have some kind of mental health issue. Electroconvulsive therapy was first developed in the 1930s. You attach electrodes to the patient's head and briefly pass volts of electricity throughout the brain. This still occurs today. They've made it a lot more safer than in the past. So today is no more physically dangerous than just kind of being under anesthesia. Researchers report 90% improvement following ECT for severe depression. And so a lot of times it is kind of one of the last steps if some kind of the drugs aren't working, if therapy hasn't worked, a lot of people will go and get a few sessions of ECT and report that it really helps. Okay. Approximately 18% of individuals in the US experience mental illness in any given year, and about a quarter of all homeless adults have a serious mental illness. Serious mental illness costs us billions of dollars in lost earnings per year. So if you're depressed or anxious, you're not going to work, you're losing that productivity, emergency care visits, all of that stuff. And adults in the US living with serious mental illness die on average 25 years earlier than others, largely due to treatable medical conditions. So people with serious mental illnesses may not be able to seek good health care. So over 40% of people with mental disorders don't seek treatment. And why might that be? So one is lack of access and being able to afford access. So accessibility, affordability are definitely big factors. There's not enough therapists out there today. There's not enough providers out there today. But even when there is affordable options for treatment, people still often don't seek treatment. And so why might this be? If we think back to our health behavior change theories, we know some constructs that are related to whether someone may or may not change their behavior, or in this case, seek treatment. One is beliefs of what others think in the form of social norms. What's the person believe others may think? And then also attitudes about mental illness and treatment may be important. Do individuals think that mental health treatment is good or bad? One such attitude is stigma. Stigma associated with mental illness has been identified as a key factor that may impede mental health service use. And stigma reduction is a central goal for many national mental health policies. So stigma can be broken down into a few distinct definitions, but overall it's a negative attitude or belief about something, in this case, mental health counseling or treatment, mental health treatment. So public stigma is defined as negative stereotypes and prejudice against mental illness. And so a public stigma thought could be people with mental illnesses are dangerous and unreliable. And I think we have a lot of public stigma surrounding mental illness, right? How an individual perceives others think about mental illness can be called perceived public stigma. So if someone with a mental illness thinks everybody else believes that people with mental illness are dangerous and unreliable, that's perceived public stigma. There's also self-stigma, which is an individual's own belief about the group that they belong, the stigmatized group they belong to. So why do we care about all of these terms? Well, I think this study is really important. In a national study of college students, students with mental illness perceived public stigma to be pretty high. So they perceived that people believed that other people held negative stereotypes about people with mental illness. And so they didn't want to seek treatment because they thought others would negatively judge them. So basically, it's I have depression, but I think most other people without depression think that people with mental disorders are weak. They just need to get over it, whatever. And so I don't want to be in that category. I don't want other people thinking I'm weak. And so I'm not going to seek treatment. So in this study of college students, the authors advocated for a campaign that basically centers around social norms to help people understand that the actual public stigma of mental illness is not that negative. So something like 90% of students report that they would not think less of someone who has received mental health treatment. So putting that kind of statistic out there can be helpful for people to realize that other people aren't going to judge them harshly for seeking treatment. So this type of message may be an effective way to increase positive attitudes toward treatment seeking. And campaigns that have similar messages have shown to be effective. So stereotypes are defined as knowledge structures that are learned by members of society. Stereotypes typically lead to prejudice, where individuals engage in these negative knowledge structures and hold a negative view of the subpopulation. And then discrimination is the behavioral reaction of prejudice. So stereotypes are kind of beliefs or knowledge structures, if you want to be fancy, that are usually negative of some kind of group of people. And then discrimination is kind of acting on those, on that prejudice, and stereotypes in a behavioral way. So not hiring someone because of that prejudice. So this graphic shows stereotypes, prejudice, and discrimination from the public toward the mentally ill. And so we'll just do self-stigma because I think this one's a little bit easier to understand. So this is someone that has a mental disorder. So the stereotype is all people with mental disorders are incompetent. So that is kind of something that we may learn at an early age. And then the prejudice is for the person with mental disorders. I have a mental illness, so I must be incompetent. And then the discrimination, why should I even try to get a job? I'm an incompetent mental patient. And so because of those beliefs and thoughts, they don't go to treatment. And they don't suffer from feeling stigmatized because they're not labeled, they're not seeking treatment. And we'll do the public stigma too, just to be safe. Okay, so the stereotype, all people with mental illness are dangerous. And then I agree, people with mental illness are dangerous. I'm afraid of them. So that's someone holding that prejudice. And then the discrimination, the behavioral aspect is I do not want to be near them. I won't hire them at my job. So, okay. So why do people hold these negative thoughts, attitudes, and behaviors about people with mental illness? So many theories and hypothesis. One is that people with psychological disorders are often perceived as if they are to blame for their disorders, that they did something to cause their disorder, or that they aren't doing enough to stop their symptoms. So a lot of times we view psychological disorders as controllable. And I think part of this is like a coping mechanism that if mental disorders are controllable, then we can control not getting them, you know. I think the one way that I have found that really makes sense about thinking about this like this is that, you know, if a person with mental illness seeks treatment 4 or 5 times, it's seen as a failure. But if someone who has diabetes is going for treatment over and over again, we don't really see that as a failure. And so kind of differentiating physical and psychological disorders, we need to do less of that because we know that physical disorders like diabetes, you know, there's a genetic component, there's a behavioral component, just like our psychological disorders. There's a genetic component, there's a behavioral component. And so we need to like stop the differentiating between them as one that you cause and one that is caused to you. Diabetes might be a bad example for that, but hopefully you understand what I mean. Okay, so how do we reduce stigma? There are 3 ways, and the first way, tell people not to hold these beliefs. That obviously doesn't work. You can't just tell people to believe something and have them truly believe you and change their beliefs. And so that one doesn't work as well. The second one, a little bit better, educating people about mental illness, telling people reasons why. So explaining that, like what we did in this lecture, mental disorders have a genetic basis or chemical imbalance in the brain. So this may help people realize that it's not a choice or something that the individual did. And there's a lot of educational campaigns out there trying to kind of get at that point, I think. And then lastly, one way that we know really helps reduce stigma is to just get people in contact with people with mental illness. So this contact method, one-on-one can help individuals see that mental illness is something that is common. So showing a real live person can make mental illness real and not just the shadowy idea or belief. And the contact method seems to work well in reducing stigma. And so this isn't like, it's not like we're pulling, someone with a severe mental illness out of the streets and having them, talk to people. It's just sometimes being really open and sharing about your struggles. I have anxiety. What does that look like for me? And then other people who, one, may have anxiety, may feel, okay, like here's someone who is functioning, who has sought treatment, all of that stuff, and may not normalize it, but may see it as something not as scary, not as debilitating, something that can be shared too. I think talking about things, being open about experiences, whether it's mental health or physical health, can be really helpful for people not to kind of, keep everything inside. And so that is something that I think too has improved over the years. Your assignment this week, watching some of these videos of people with mental disorders, you can see some of them are celebrities. And we've talked about this before with physical disorders, physical ailments, that again, kind of talking about some of these can help bring attention to it, bring awareness to it, and help people feel like they're not alone in their struggle. And especially, I think for younger adults, teens, being like, oh, she has, you know, um, I forget which one's like, I don't know, there's one of the singers that I think is bipolar. Like she has bipolar and look at, what she's been able to accomplish, or, I'm not that strange. I'm not the only one. I think that can really help younger people see and be able to help deal with and hopefully seek treatment for their mental health. Okay, so we talked about mental disorders. We talked about some of the factors that may help develop certain mental disorders. We talked mainly about anxiety and mood disorders and some of the disorders that fall under that. And hopefully you can differentiate between those common disorders. And then lastly, we talked about prejudice, stereotype, and discrimination and factors reducing stigma.